My name is Stacy Hart, and I'm here with Kathy Gibbs. We are excited to speak to you about the Americans with Disabilities Act as it applies to healthcare providers. But first, a little bit about the organization I work for, or that we work for. We work for the New England ADA Center, one of 10 regional centers across the country that provide information and training on the Americans with Disabilities Act. We are here to help and support compliance with the ADA. We are not an enforcement agency. So anyone can call us and we are confidential. We're fortunate to be housed within the Institute for Human-Centered Design, an international nonprofit focused on enhancing the experiences of all people, ages, and abilities uh, for people from different socioeconomic backgrounds. We really believe that design can enhance an experience or hurt it, as the case may be. We have a jam-packed agenda today. Um, so first we'll start with a history of the ADA, followed by who is a person with a disability. Then we'll talk about effective communication and auxiliary aids and services. Kathy will take over at reasonable modifications of policies, practices, or procedures so that people can participate, followed by medical equipment, and then language. Wow. So first, a little history. People with disabilities were penalized in this country for even existing for quite a long time. Many states had what were known as ugly laws, and so it was illegal to go out in public as this man with cerebral palsy was arrested at a restaurant for meeting his friend. Also, people with intellectual disabilities or cognitive disabilities were institutionalized for life. If a child with a disability even received an education, it was in a special classroom or even a separate institution. And then somehow um, the ability to vocalize was equated to intelligence, and we know that that's just not the case. Two of our civil rights laws, and there are several more, but first, the Section 504 of the Rehab Act. It was the first civil rights law in which the federal government took an active role in ending discrimination of people with disabilities solely because they had a disability. And they did this by tying compliance with federal funds. So Section 504 applies to any federal agency and then any organization that receives federal funds, but that left a lot of businesses and organizations out. So then we passed the Americans with Disabilities Act. Similar to 504, the ADA provides a comprehensive national mandate that says you cannot discriminate against someone solely because they have a disability, and they have the right to participate in all goods and services. When we talk about the ADA, we talk about it in terms of these five titles. Title one, employment. So if you have an employee with a disability that needs a reasonable accommodation, that's Title one. Title two, state and local government, applies to any services that the municipality offers citizens. So your city hospitals, your county health departments would fall under Title II. Title III, public accommodations or private businesses, nonprofits open to the public. So all of your private hospitals, your private practices, and any amenities offered within the hospital. Title IV, telecommunications or the relay service, allowed people who are deaf or hard of hearing or people with speech disabilities to access the telephone. And then Title V, everything else that the Department of Justice wasn't quite sure where to put. So the ADA applies to all healthcare providers, from your private hospitals to your private practices to your urgent clinics to your CVS pharmacies, and then any amenities that you might find within these healthcare services. So your food services, your gift shops, etc. Your your group meetings. So like when I had my first child, I attended uh, parent baby classes, and that would be covered as well. Next, who is a person with a disability? Here we have pictures of our interns, uh, and they have a variety of disabilities from mobility to disabilities with sight as well as hearing. Who is a person with a disability? Well, there are lots of definitions out there, but when we talk about the ADA, this is the definition that we're referring to. So, a person is a person with a physical or mental impairment that substantially limits a major life activity. So that could be anyone with multiple sclerosis or Parkinson's, bipolar, addiction to alcohol, and many more. So this person has a disability under the ADA. The second part of the definition is a person with a disability who has a history of such an impairment. So someone who had cancer, that cancer is in remission, they would be a person covered under the ADA. Or someone who is in recovery from an addiction to heroin or opioids, they would also be covered. And finally, the third part of the definition is someone who is treated as if they have an impairment regardless of the actual fact. And there's a negative consequence because of that belief. To be protected under the ADA, a person only has to meet one of the three parts of the definition of disability. The New England ADA Center wanted to know how many people in New England had a disability as defined under the ADA definition of disability. And so we took our 6 New England states and we have statistics for each one. But let's look at Connecticut. The ADA Center found that 26% of Connecticut citizens have a disability, 10% have mental health disabilities, but only 1.4% of people use a wheelchair. And this statistic surprised us a little bit because the stereotype of disability is someone with a mobility disability, often someone who uses a wheelchair. Does this statistic surprise you guys or these findings? As we age, we are more likely to acquire a disability. So we age into disabilities. Many of those impairments, many of the most common impairments, affect our mobility from arthritis to back problems. But we also have things like respiratory and diabetes, and then we have sensory disabilities. So as we age, we are more likely to lose some of our ability to hear, we're also more likely to lose some of our sight. And 20% of people have a co occurring sensory disability, meaning loss of hearing and loss of sight. And oftentimes, if we age into our disability, we're less likely to see it as a disability and more a part of the aging process. So we may or may not ask for accommodations. We may or may not admit that we can't hear or see. There are many, many different types of mobility disabilities, and that will affect the device that is being used. So we have a young girl in a power chair. She has spina bifida. Distances don't matter as much for her, but space does. So in considering design, look at the layout of the space. The next person is a young lady who was in a car accident. So she is a paraplegic and can use a manual wheelchair to navigate her environment. Distances do matter, so that's important when thinking about design. The older lady has arthritis. She uses a walker. It's important to think about places to sit when designing spaces. And then the young man has cerebral palsy. He can walk short distances with forearm crutches around his dorm room and the like, but needs a scooter or a battery operated mobility device in order to cross campus and travel further distances. For him or for people who use scooters, it's important to know that they're more likely to transfer out of their mobility device and that you might need to think about places to store mobility devices. When interacting with people who have mobility devices, remember that the person's mobility device is a part of their personal space, so don't touch or move, including wheelchairs. There's a tendency to use the back of a wheelchair as a leaning post. Don't do that. When talking with someone who uses a wheelchair, sit down so that you're at eye level. When interacting with someone with a cognitive disability or an intellectual disability, speak to the person with the disability, not their companion. Be concise, check in with the person, make sure that they're understanding what you're trying to communicate, and avoid acronyms. Most people with disabilities have non-apparent disabilities. Um, about 85% of people with disabilities have a brain-based disability. So you may or may not be aware of a person's disability upon first sight, whether it's someone on the autism spectrum to someone with an epilepsy or a mental health disability. And we have a picture of Temple Grandin on the screen and then someone with Tourette's syndrome on the screen as well. Your communication with people with disabilities has to be as good as your communication with other people, other patients. So it was initially believed by, or the stereotype of the ADA was that the ADA only applied to people with physical disabilities, which isn't the case, but this provision of effective communication was specifically added for people who are blind or low vision, people who are deaf or hard of hearing, or people with speech disabilities. First, let's look at people with hard of hearing. You can be any age and be hard of hearing, but as we age, we're more likely to lose some of our hearing, and we may or may not wear hearing aids. People who are deaf, who are born deaf in the United States, often learn American Sign Language as their primary language. It has its own grammar and syntax, which will affect the auxiliary aid or service that you provide that will be most effective for the person. So people who consider themselves culturally deaf, they're part of a community. They being deaf is not considered a disability, and American Sign Language is their primary communication method.
I'm sorry, Stacy. Oh, there we go. Thank you.
Yeah. People who are lowercase d, deaf, do not associate themselves with the deaf community or the deaf culture. Hearing loss is a medical condition. They are quite comfortable in the hearing world and with English, and they may or may not use American Sign Language. When communicating with someone who is deaf or hard of hearing, speak normally. So don't exaggerate your words, don't over enunciate, don't speak louder. Speak as you normally would. Make sure that the person can see you because a lot of communication is nonverbal, visual communication. And so people need to see you in order to fully understand and communicate. So that might mean moving to another location with better lighting and with a plain background. Also, glare is a big issue when you're trying to um, see what someone is trying to say. Don't distort your facial features because, again, a lot of communication is visual. If the person isn't looking at you for any reason, stop talking. And then I'm a big believer of providing important information using multiple means of communication. So providing it in writing, sending it in an email, what have you. And then remember that communication is only 60% of communication can be seen on the lips. When interacting with someone who is deaf or hard of hearing, make sure you use a clear mask because a person needs to be able to see your facial features. Also, the requirement of providing effective communication not only applies to the patient, but also the companions that the person might bring with them. Whether that's a family member, a spouse, a partner, a friend. So, anyone you would normally have communication with and where it's appropriate to have communication with, you would need to provide effective communication to that person as well. Communication should always start with good communication, and the time and talent of staff can't be underrated. However, oftentimes good communication is not enough, and so you will need to provide an auxiliary aid or service to ensure that communication is effective. When trying to determine what would be the most appropriate auxiliary aid and service, first give primary consideration to the person's preferred method of communication. Then consider the complexity of the communication. So, radiology is on the second floor is different than, say, post surgery care instructions. And then how long will the communication or the meeting be, and the environment in which the communication is taking place. There are different obligations depending on whether you're a municipal organization, if you receive federal funds, and then if you've entered into a settlement agreement with the Department of Justice. These three entities need to give primary consideration to the request of the individual. Title III organizations or private hospitals, private doctors' offices need to consult with the individual. And then ultimately the decision rests with the healthcare provider, but the auxiliary aid or service that's provided needs to be effective. So the first auxiliary service is interpreting. The interpreter needs to be able to interpret both expressively and receptively. And then in this case, they need to know medical vocabulary. The obligation rests with a healthcare provider to provide the auxiliary aid or service. So you can't say, Mr. Patient, please bring your own interpreter. Now, if there is an emergency, and this is the only exception, if there's an emergency or threat to safety or welfare, then you can have the companion communicate that with the patient who is deaf. But that's really the only time. Also, sometimes a person who uses sign language may prefer to bring a companion that can also sign. And this is fine as long as the person with the disability requests the person to interpret, the person agrees, and it's appropriate under the circumstances. And sometimes it's not appropriate. So the companion may not be fluent in sign language. They may not be able to communicate bad news, or they may have a personal stake in the outcome. We have had hospitals call us and say, this patient brought a companion and we've tried to use them as the interpreter, but we don't feel like they're interpreting everything for whatever reason it may be. So our recommendation to that person is to hire a sign language interpreter to double check that everything is being communicated, especially I think it happened to be heart surgery or congestive heart failure. So it was very important that all of the important information is communicated. When using a sign language interpreter to communicate with someone who is deaf, um, make sure that you're looking and communicating with the person who is deaf. Remember that the interpreter is only a medium or mode of communication. You're not actually interpreting, you're not actually um, speaking with that person. An interpreter can work one-on-one or in a group setting, say a patient care meeting. Just make sure that the interpreter and the person who is deaf can see everybody. Speak one at a time and say your name with each time you speak, and then pause to make sure that the interpreter can communicate everything that's being said. Video remote interpreting is another auxiliary aid or service that allows someone to access sign language if the interpreter cannot be there in person. And it's important to remember that in-person sign language interpreting is still the preferred method. So the video remote interpreter connects someone who hears but cannot sign and someone who is deaf who needs American Sign Language. But the interpreter can be anywhere uh, in the United States as long as the technology is there. So there's a computer, iPad, video camera, speakers, microphone, and good internet. Because if there's a significant lag, then a video remote interpreter won't be appropriate. Also, staff need to be trained on how to access the video remote interpreter that the hospital has contracted with. And that brings up another point. It's important for the medical provider, hospital, uh, private practice, what have you, to try out several different interpreting, remote interpreting companies to make sure that the interpreting service is accurate and effective. We've had some very good experiences, but then early on, um, some interpreting that wasn't very effective. Video remote interpreting can be effective, even though the preferred method is an in-person interpreter. But there are some times where video remote interpreting can work. So when the appointment is routine, the medical care is routine, um, that could be an appropriate time to use this auxiliary service. When there's no in-person interpreter and there's an emergency. So until an in-person interpreter becomes available, video remote interpreting would work. And then there are certainly many situations in which the video remote interpreting would not be effective. When a person has come out of surgery, when they're not able to see the screen, when there's a significant lag time, this wouldn't be effective. Video remote interpreting can work one-on-one and it can also work in a group setting, um, say for a patient care meeting. So again, the technology has to be there. Computer, laptop, microphone, speakers, video camera, good internet connection, so no lag time. Staff need to be trained, and um, the interpreter still needs to be effective. Assistive listening devices may work for someone who has lost some of their hearing, and so there are three main types: FM, infrared, and loop. There needs to be signage letting the person know that an assistive listening device is available. They need to be kept in working order. So the batteries need to be changed. They need to be tried out um, periodically, and staff need to know how to use them. Computer aided real-time transcription. So this auxiliary service, cart reporter types everything that is being said, and then everything that can be heard. So laughs, noises, crashes, everything is typed and appears on the screen. It can work one-on-one and in larger settings as well. Just like with video remote interpreting, you can have remote cart. And so everything that is being said and heard is typed up on the screen, and then you read that on your screen. TTY was the really the first, or one of the first methods that someone who was deaf or hard of hearing, someone with this speech disability could access the telephone. And so someone with the TTY can um, connect directly with another TTY user, or they can contact the relay service and which then the communication operator will then connect with a hearing person. So hospitals are required by regulation to provide TTYs if necessary for someone to make a phone call. And then the relay service, not to be confused with video remote interpreting. So the relay service connects two people, one who is hearing to someone who is deaf or has other disabilities that make using the standard telephone difficult. And so that communication assistant communicates messages back and forth for that person. There are many ways to connect with the relay service, from video relay for someone who knows American Sign Language to hearing carryover, so someone who can hear but not necessarily speak or have a speech disability, so they can listen and then um, type or sign a message to voice carryover. Someone who can't hear or can't hear well, um, but they can voice their message to the first technology, TTY. Someone with a teletypewriter can communicate with someone who doesn't have one. So again, video relay services connects someone who signs with someone who doesn't through a communication assistant, and it can be used in either direction. So I have received video calls, and then I've also placed video calls um, to our callers. Also, video relay services cannot be used as an interpreting service. It's for the telephone. When you have videos on your website, make sure that you caption those videos. Moving on to people who are blind or have low vision, um, people may access their environment through the use of white cane or through the use of a service animal, or they may not use um, any assistive device. I rode before COVID the commuter rail with a man who said, you know, for a long time I did not use a white cane, and so it may be someone's choice who has aged into vision loss to not use a white cane or a service animal. People who are blind and people who are low vision use different types of technology to access information, from a magnifier to large print. When communicating with people who have visual disabilities, identify yourself each and every time. Hello, it's Stacy. How are you doing today? They won't necessarily know you by your walk or your perfume. Speak facing the person. Again, communication is visual, and so a lot of people with vision disabilities have some sight. And then everything that we take in through our eyes to be described to the person. So describe the room, where to sit, etc. When leaving, let the person know. Otherwise, it's rude, but also they may or may not realize that the conversation has ended. And then don't pet the service animal. They're working. General directions are not helpful. So, not helpful. Watch out. Be careful. I don't know how often, and I'm not a person with a vision disability. I do have a vision, I do have a disability, but I don't know how often I'm told to watch out, slow down. It doesn't really change things and it's not helpful. Be specific. So turn around and the elevator is about 20 paces behind you. Be careful is fine as long as it's placed, as long as it's followed by an explanation. Be careful, the floor in front of you is wet. Not helpful. Grabbing the person. Don't touch the person. Respect someone's personal space. Um, you can certainly offer assistance, but let the person take your elbow and not the other way around. And that's true regardless of the type of disability. Don't assume that you know how to help the person or even that the person needs help. There are three main ways to be a human guide. First, if a person has a service animal, they may just say, follow to the service animal, and the service animal will follow you. You can walk at your normal pace. You can even have a conversation with the person. The next way would be to make a wing with your arm and offer your arm to the person. They will take your arm above the elbow. Again, they're taking your arm, you're not touching the person. And let them know about any environmental changes, whether there's a narrowing in the path or there's stairs or an elevator. And then the third way is for the person to take a hold of your shoulder so that they're a step or two behind you, because otherwise you're twice as wide. And if they've never been guided by you, they might be afraid that you will run them into uh, part of the environment, an obstacle. So here's hopefully a thought-provoking question for you. A patient who is blind has been diagnosed with high blood pressure.
Sorry,
After meeting,
can we stop for 1 second? We're trying to switch interpreters again, and we're just waiting for the spotlight. Could we spotlight Lou, please?
yep, a spotlight Lou, sure.
Thank you.
All right, so a patient who is blind has been diagnosed with high blood pressure. After meeting with the doctor, patients are given handouts to help them manage medication and lifestyle changes. What may this patient need to access the information? They might prefer Braille so that the information be provided them in Braille, but only 10 to 20% of people who are blind or low vision have learned Braille, so this is only effective for a few. Providing an accessible document either through email or thumb drive might be another way of providing access. Remember, the document itself must be accessible so that the person can use their preferred technology. So whether it's reading it on their laptop and having it read to them and then using refreshable braille. providing the information in an audio format, whether it's an MP3 file or another um, technology. You don't have to provide them with an MP3 player or an iPhone, but an audio file that is accessible might be another auxiliary aid. How about this? A patient signs up for your Healthy Baby class. She has a learning disability and a vision impairment. She requests large print versions of the material. What do you do to address her request? You provide it in whatever font size that person requests. We've had someone request uh, fonts of 54-point fonts. So we have provided that to the person. If you have brochures or other materials that patients can take with them, um, we recommend going a step further and providing a large print section, 18 to 22 point font. The time and talent of staff cannot be underutilized. So a person might prefer that staff read them the post-care instructions. That could be appropriate for this individual. Moving on to people who have speech disabilities. So there are people with speech disabilities that do vocalize, but then there are other people who communicate with through technology. So here we have someone who types in the message on their iPad or laptop and then can hit a button and that message is uh, audio wise, it's vocalized through the computer speaker. And then we have communication boards from low tech to high tech. This is a communication board that the hospital might want to have on hand. When working with someone who has a speech disability, don't interrupt while they're trying to speak. Don't just nod as if you understand if you really don't. Again, the patient might not tell you that they don't understand you, and it's important to check in, but the reverse is also true. You need to make sure that you understand them. Ask yes or no questions that are in um, neutral. So you can't say, "You're brushing your teeth, aren't you?" if you're a dentist. Well, that automatically says to the person, I'm supposed to say yes, regardless. So the yes and no question does need to take work. Make sure that they're neutral. Also, paraphrase back what you think the person is trying to say so that you ensure effective communication. If you don't understand, be honest. When providing an auxiliary aid or service, a healthcare provider is required to provide the auxiliary aid or service no matter how much it costs. True or false? False. So you're not required to provide an auxiliary aid or service if it would cause an undue financial or administrative burden. But you have to consider all of the resources. We get calls from medical providers, healthcare providers, and they say, but the interpreter will cost more than what we're reimbursed for the appointment through insurance. And we do understand that issue, but it's not enough to consider the cost of that one um, patient meeting, it's your whole budget. Your websites need to be accessible. And the Department of Justice has defined that as conforming to the Web Content Accessibility Guidelines 2.0. Be sure, so what does that mean? It means things like being able to use the website without a mouse, because people who are blind or low vision can't see the cursor. Provide alt text or text descriptions for images and photos on your website. If it's important enough to put up, it's important enough to describe. Also, you want high contrast. The higher, the better. So dark on light, light on dark. And then an extra sophistication would be to allow the user to control the colors in which they see information on the screen. And then minimize movement and flashing on the screen because it's distracting. It can also set off seizures for some people. Now, Kathy will discuss settlement agreements that the Department of Justice has entered into with hospitals. And it's important to know that settlement agreements go beyond the specific word of the regulations, or they often do.
Hi, everybody. Can you hear me and see my screen? Yep, okay. So I'm Kathy Gibbs. I'm the Director of Training at the New England ADA Center. I'm a colleague of Stacy's, and the Department of Justice has had really a long-standing concern about access to medical care, mainly for people who are deaf and hard of hearing. I mean, they're concerned about access for medical care for everybody with a disability, but there's been a big focus on making sure that people who are deaf and hard of hearing have access. And so there have been quite a number of hospital settlement agreements. And as Stacy said, these go way beyond what the ADA Title III regulations or Title II regulations require. But the Department of Justice can come knocking. They can respond to a complaint and enter into a settlement agreement based on a complaint, but they can also just contact a healthcare provider and say, we'd like to do an ADA review, and then they will negotiate a settlement agreement. So they're all sort of variations on a theme. They all require what's called a communication access assessment. And then they all require, and the settlement agreements have used different terminology, but basically the healthcare provider has to assign at least one person, if not two people, to be the ADA coordinator, or sometimes they call it the assistive technology person or the designee. They need to keep a service log, establish a grievance procedure, establish notification, and training. So I'm going to go over a few of these so you can get some of the detail. There's a model communication assessment form which the Department of Justice has created, which they want healthcare providers to use when they're assessing people's communication needs. And those are supposed to take into account the individual's skills and knowledge, the nature and complexity of the communication, and also the patient's preference. So we've talked a lot about American Sign Language, but there are many other kinds of sign language. There's sign language for people who are deaf blind. There's sign language for people who, it's called plain signed English. So it really has to do with what the patient's preference is in terms of their mode of communication, and also, as I said, the nature and complexity. The assessment is supposed to occur at registration, or when the person makes their appointment, or their first contact with a clinician. That's going to determine the appropriate auxiliary aids and services. The results are supposed to be kept in the patient's chart and reassessed only if the initial auxiliary aid and service isn't effective. Now, the ADA coordinator or assistive technology person designee if it's a hospital setting, the person has to be available 24/7. So that's why I said it's going to be more than one person, because no one person is going to be available 24/7. But if you're a healthcare provider and you're open from 8 to 6 or whatever it is, again, you might want to have 2 people sort of depending on the shift. The ADA coordinator is the person who's supposed to answer all questions and assist staff regarding anything having to do with auxiliary aids and services, know where they are stored and how to operate them, be responsible for the upkeep, the distribution, and the replacement. So what we find often happens is that, and this isn't just hospitals or healthcare providers, it's sort of lots of organizations and businesses will buy things like an assistive listening system. And maybe they don't use it for a month, or maybe they don't use it for 6 months, whatever. And then when somebody finally requests it, does everybody say, oh, where is it? How do you operate it? I'm not sure we've got batteries that are operating. Does anybody have spare batteries? I mean, I've seen this so many times. So that's really why the Department of Justice wants to make sure that at least one person is responsible for everything having to do with the auxiliary aids and services. Now, I also want to say, because the ADA requires so much more than just auxiliary aids and services, we really recommend that the ADA coordinator be the point person for everything having to do with disability related requests. So if somebody makes a request to have their service animal with them, and the admission persons or whatever isn't sure that that's something that's required, or if that's a good idea, the ADA coordinator could be intervening and could be the point person on those kinds of issues. But the settlement agreements really concern auxiliary aids and services and effective communication. Excuse me. Then the other thing that the department requires is a grievance procedure. So they would like to see that grievances are taken care of within the business of the nonprofit organization. You are supposed to provide a written response to a complaint within 14 days of receipt of a complaint. And a complaint does not have to be written. It can be oral. So if an oral complaint is received, that's valid. You can certainly ask somebody to follow it up with an email, but you've received a valid complaint. Records are supposed to be kept of the grievances, whether they're oral and written, as I said, and then any actions that are taken. So the settlement agreements also have a focus on, training for any staff interacting with patients and the public. So how to identify the needs and preferences of patients and companions who are deaf or hard of hearing, how to secure qualified interpreter services quickly, how to operate the video interpreting services equipment. And this was something interesting, because I never actually saw this anyplace else. The Department of Justice talks about using flashcards and pictographs in conjunction with other means that augment communication. So this is probably a good idea. A lot of people respond much better to sort of visual cues like pictographs. And then notification to patients and the public. So it's very nice that we're doing all these things, but the department says, okay, now you really have to notify people. So that we're in compliance with the ADA, how to request an auxiliary aid and service, and how to file a complaint. So this would be whatever procedure the hospital or the healthcare provider wants to come up with. We want to make sure that people can figure out how to actually do that. So, and the settlement agreements really don't go into any specifics. So these are our recommendations. I think the first one is probably pretty obvious, that there be information on the healthcare provider's website, that there be a information provided before the appointment, that the information be provided, at the appointment. If you have a patient handbook, information can go there. Certainly a patient bill of rights, if you've got that, that would be a good place to put that information. At a hospital, when you're admitting somebody, social media. Many of us have various kinds of social media, Facebook pages, or we're using Instagram or Twitter or something. And then the old-fashioned method of bulletin boards in hospitals, bulletin boards in buildings, so that people can see it when they're in the building. The other thing the settlement agreements go into a fair amount of detail is when are sign language interpreters required. And the Department of Justice uses this phrase, complex situations. So Stacy went over some of the places where it might be more appropriate to have a sign language interpreter, and where it might not be as necessary, but the department in the settlement agreements goes into a fair amount of detail. So discussing diagnosis, symptoms, medical history, medication, explaining treatment options, tests and surgery, obtaining informed consent for treatment, providing instructions for post-treatment and follow-up, information about blood or organ donations, if you're holding new parent classes or nutrition programs or first aid training. And then finally, complaints against the hospital. Somebody might need an interpreter in order to do that. And certainly, if you're going to be having a discussion with the person about their complaint, because a complaint doesn't have to just be the person complains and then you sort of respond yes or no. It always would make sense to have kind of an interactive process to discuss the person's complaint. That might be another place where it would be appropriate, would be considered a complex situation. There's some discussion in the settlement agreements about timelines, and for non-scheduled appointments, it would be within 2 hours of a completed assessment for interpreting services or staff that are located offsite, and then 30 minutes from completed assessment for video remote interpreting service. And it's pretty easy to arrange video remote interpreting services as you need it. It's not usually something that you have to arrange ahead of time. So it really shouldn't take more than 30 minutes to get that going. And then in terms of scheduled appointments, of course, you would want to make those arrangements at the time of appointment. So that's a lot about effective communication Stacy talked about, and that's the Department of Justice settlement agreements on effective communication. So next I'm going to talk about sort of some of the general non-discrimination parts of the ADA and what's called reasonable modifications. So get into some details about that. So here we have a photo of a man who is blind with his seeing eye dog, his service animal. And the situation is he accompanies his wife to her cardiologist appointment, and the security guard won't let him in because of the dog. And the question is, has the healthcare provider violated the ADA? And the answer is yes. Now, one of the issues we often find is that people will attend trainings and learn about the ADA, but it doesn't necessarily get down to the level of the people who are actually interacting with the public. So the security guard hasn't necessarily been through an ADA training or understand the healthcare provider's obligations. So it's really important that anybody who's interacting with the public, and particularly in terms of the things that Stacy was talking about with the video, the relay system, where you might get a phone call, either a TTY phone call or a video phone call, that anybody who's answering the phone knows that they may receive a relay call, but also anybody who's opening the door or letting people in really needs to understand their obligations under the ADA. So this is sort of basic ADA, general non-discrimination. No individual shall be discriminated against on the basis of disability in the full and equal enjoyment of the goods, services, facilities, and privileges. So that's directly from the regulations. I kind of like to turn that around and really think about what we're doing as providing an equal opportunity for people with disabilities to participate. So it's sort of a little bit more positive way of thinking about it. But there is something in the ADA that's called direct threat. And this is, again, an excerpt from the regulations. So nothing shall require an entity to permit an individual to participate in or benefit from the goods, services, facilities, privileges, advantages, and accommodations of such entity where such individual poses a direct threat to the health or safety of others. And I'm going to get into COVID a little bit, but before, because this is a big issue, the direct threat and COVID. But before I do that, I just wanted to talk about this really interesting Supreme Court case, which actually is quite old. And it took place, the situation took place in a small town in Maine. And it's kind of interesting because this little case in Maine made it all the way to the Supreme Court, which is not that easy to do. When you file a complaint, and you have to have a lot of appeals, and you kind of go all the way up the court system. And then all the cases that come before the Supreme Court, they are not required to decide them. They are very picky about what they decide, but they thought this was important, so they took this one on. And this situation, Ms. Bragdon disclosed that she was HIV positive. She just disclosed it during the regular medical information that doctors and dentists asked about. And the dentist refused to fill her cavity in his office. He said he would fill the cavity in hospital. And he also required the patient to pay for the expense of using the hospital. So the Supreme Court determined, and this was based on professional testimony, including from the American Dental Association, that there was no direct threat if the dentist used universal precautions in his office. Now, the big issue that has come up for us with direct threat and COVID-19 really has to do with face masks. We get many questions, both from businesses and nonprofit organizations and state and local governments, and also from people with disabilities about, what do we do if a person with a disability is unable to use, or it's very difficult for them to use a face mask due to having a disability. And it could be that somebody has asthma, or they have anxiety disorder, or they have COPD. So there are many situations where it might be difficult or really impossible or dangerous for somebody to use a face mask because of COVID-19. I also do want to acknowledge that there have been many people who have abused the ADA and have used the ADA falsely to say that the reason that they can't use face masks has been because of a disability. And so, in fact, there was one group that came out with a warning with the Department of Justice phone number and seal on it, which wasn't from the Department of Justice at all, warning businesses that there could be a $75,000 fine. So it's been a bit of a hot issue. So here's the issue, or here's part of the issue. Under COVID-19, everyone is considered to be a potential direct threat. And in many ways, that's because anybody could be asymptomatic. You could not have symptoms and still have COVID-19. So this is a determination. We are looking at the Centers for Disease Control recommended protocols. As those protocols change, hopefully as the vaccine takes effect, I'm sure the CDC's protocols are going to change. And so medical providers and all businesses and any entity may have policies addressing direct threat issues, such as requiring masks and social distancing. But here's where things get a little bit complicated, which is that because under the ADA, medical providers and all businesses must consider making reasonable modifications of policies, practices, and procedures for people who can't wear masks due to a disability, such as asthma or an anxiety disorder. So for things like, let's say a small store, that's going to be something like curb service or delivery. For medical providers, it's really a little bit more difficult because you're needing to maintain a safe environment. I mean, we're all needing to maintain a safe environment, but do need to consider, are there reasonable modifications of policies, practices, and procedures that would allow somebody who can't wear a mask due to a disability to access your medical services? And I think it's going to have to do with things like, how large is your space? Where can you use plexiglass? Are there additional means for providing protection? Let's say for the medical providers, is it multiple masks or is it masks and a shield? And I do want to say one thing about face shields. They are not a substitute for masks. They are really intended to protect your face and your eyes. And they certainly help in terms of, not having direct hit of somebody's, what do they call it, the droplets or whatever it is, but they're not providing the same amount of protection as masks. So this is a bit of a tricky issue. Many of us have asked the Department of Justice, please give us a little bit more guidance on how we balance out this direct threat and the requirement under the ADA to make reasonable modifications of policies, practices, and procedures, but we haven't gotten anything from the Department of Justice yet. We're still hoping that's going to occur. So moving on to other kinds of reasonable modifications of policies, practices, and procedures. Very often people use the term reasonable accommodation. That's a term in Title I having to do with employment. Titles II and Titles III, and by the way, the Department of Justice wrote the Title II and Title III regulations. So when we're talking about the regulations, that's what we're talking about. And both of the Title II and Title III regulations say when it's necessary to ensure people with disabilities have an equal opportunity to participate, reasonable modifications must be made to policies, practices, or procedures. So we got this phone call. A father and a daughter went to an urgent care clinic, and the father asked if his daughter could be seen immediately because she has attention deficit hyperactivity disorder, and it became easily agitated and act out. Now this was pre-COVID, where anybody could be in an urgent care clinic, and it was really first come, first serve. Is this an ADA issue? Yes, this is an ADA issue. We've got somebody with a disability, attention deficit hyperactivity disorder, who requests a reasonable modification of a policy, practice, and procedure. And we thought this was a reasonable modification of a policy, practice, and procedure, and that this is something that the medical provider really needed to consider. Another reasonable modification request was this situation where Mr. F sent an email to his doctor's office concerning his appointment, and he said that he has multiple chemical sensitivity and must be in a building that has used only unscented cleaning products in the past week, and where no one is wearing perfume, cologne, and other scents. And so the question that we got was, is this an ADA obligation, and what needs to be done to address his request? So again, yes, this is an ADA issue. He has multiple chemical sensitivity, which is considered to be a disability. Now, in terms of the request, it's really two requests. So I had to really divide this in two. The first request had to do with using only unscented cleaning products in the past week. So that's one decision. Can a medical provider, keeping the level of cleanliness and sterility that they need to keep, are there unscented cleaning products that would allow them to do that? And the medical provider decided yes, there were. Then the second question was about no one wearing perfume, cologne, and other scents. So what the doctor's office did is they sent out an email or called all of the patients who were coming and asked that requested, in consideration of people with disabilities, please refrain from wearing perfume, cologne, and other scents. They were not required, doctor was not required to stand at the door and sniff people as they came in. And so they basically, sent an email back to Mr. F and said, here's what we're doing. We hope that it's going to work out for you to come to our office. Service animals are another reasonable modification. And initially, back in 1991, when the regulations came out, there was no real definition of service animal. And so people were saying that there's snakes and there's turkeys and all sorts of things were service animals. So in 2010, the Department of Justice amended the regulations and said any dog individually trained to do work or provide tasks for the benefit of an individual with a disability, including a physical, sensory, psychiatric, intellectual, or other mental disability, would be considered a service animal. So on the left, we see a woman who is blind with her seeing eye dog, and on the right, we see a rabbit who is not considered to be a service animal. So we can have service animals. People with autism have service animals. Here's a photo of a mother and her son who has autism, and the service animal talking to a psychologist. People with mobility disabilities might have service animals. The young boy on the left who has cerebral palsy is using a service animal for stability, and the woman on the right is using her service animal to retrieve something like a can of Coke from a shelf. People who are deaf or hard of hearing might have service animals. They could alert the person to a door knock, or the presence of a person standing behind, or smoke detector alarm, or traffic approaching. And then people who have epilepsy, dogs have been trained to figure out when somebody's about to have a seizure and to stay with the person, to lie down with them if they're on the floor. And then many animals have been trained to detect the presence of allergens and to let somebody know that the cookies have peanut butter in it or whatever. There's also service animals for people with mental health disabilities that remind the individual to take medicine or turn on the lights for somebody with post-traumatic stress disorder, interrupt self-mutilation, and keep disoriented individuals from danger. What's not considered worker tasks, and on the right we have a very cute dog with a little emotional support animal vest on. So the crime deterrent effects of animals' presence are not considered worker tasks, and the provision of emotional support, well-being, comfort, and companionship are not considered to be worker tasks. So emotional support animals are not required to be allowed into places under the ADA. And there's only two questions that can be asked. Is the dog a service animal required because of a disability? And what worker task has the animal been trained to provide? Now, the other thing that happened in 2010, and here we have two photos of people who are blind with miniature horses. Miniature horses are a possible service animal. Some people, usually they're used by people who are blind. They might prefer them because they live a lot longer than dogs. They have peripheral vision. And also for some religions, dogs are considered unclean, but horses aren't. There are assessment factors that you can use. You don't necessarily have to allow a miniature horse everywhere that you allow a service animal, that you have to allow a dog. It could depend on the size of the facility, how large the dog is, the horse is. So it's not quite equal to being a dog service animal. So a little scenario, Ms. R has an appointment in your facility. She has a service dog because of a disability. The service dog growls when someone passes by. Do you have to allow this? And the answer is basically no. You might want to ask her to get her dog under control. The animal has to be under the control of the handler at all times, basically on a leash or harness, except in very narrow circumstances. So on the left, we have a seeing eye dog who has a harness on, and on the right, we have a woman in a wheelchair who has her service animal that's on a leash. And the narrow circumstances might be that the animal has to retrieve items. So on the left, we have a young boy and the dog is bringing him a book, a children's book. And on the right, we have a man who's in a wheelchair and the dog is bringing him a cane. And the other narrow circumstances is because the person is unable, because of the disability, to hold a leash or use a harness, but this animal still has to be under the person's control. Service animals in training, and here we have a photo of a very cute little puppy, service dog in training, vest on. The ADA does not require allowing service animals in training, but coverage is required by some states, like Connecticut. So you do want to, check your state law. So that's a brief run through of general non-discrimination, reasonable modifications. I'm going to talk a little bit about medical care facilities and assistance. So this was another settlement agreement, Department of Justice. It was against, or with, I should say, Charlotte Radiology. The complainant has paraplegia and uses a wheelchair, and she needed assistance to transfer to the bone density machine. And the healthcare provider said, no, we have a policy that staff did not transfer patients. So she filed a complaint with the Department of Justice. And what the Department of Justice required was that the Charlotte Radiology adopted non-discrimination policy, which the Department of Justice provided, that required modifications to policies such as providing assistance. And then they required that it be posted in offices, waiting rooms, exam rooms, and employee areas, and also that a hyperlink to the policy be on the website's homepage. Also required that when scheduling an appointment, staff has to ask all patients if they need a reasonable modification because of a disability. And then they required administrative staff who interact with patients or prospective patients to attend a training. And they were also required to purchase or lease at least 2 or more lifts designed to, to transfer a patient to the bone density machine. And at some point during all of this work that the Department of Justice is doing the settlement agreements, they decided to come out with this publication called Access to Medical Care for Individuals with Mobility Disabilities. And there's an image of it on the website, I'm sorry, on your screen. And the way to access it is through the Department of Justice's website, which is www.ada.gov. So a few of the things that they say in this publication is that they want medical providers to examine a patient who uses a wheelchair on an exam table if that's how you examine others. Provide assistance with dressing and undressing, getting on and off the exam table or positioning. And they may need a staff person to stay with them to maintain balance and positioning. And then there are a lot of illustrations, and this is one of an exam room that shows the requirement to have an accessible route to the exam room, to have a 30 by 48, let me just go back, 30 by 48 inch space next to the exam table so that somebody can make a transfer from their wheelchair or their walker or their canes onto the exam table. That they would like to see a turning space in the exam room. This is not required, but highly recommended because it's difficult for somebody who's using a wheelchair to turn around in tight spaces. They would like to see transfer space on both sides of the exam table, as we have here, because some people transfer from their right and some people transfer from their left. And then adjustable exam tables and transfer lift systems. So here's 3 images of different kinds of lifts. 2 of them are portable, and the one on the bottom is permanent. It's installed on the wall. And concern about mammography machines, making sure that there's an accessible route to the mammography machine and that they go lower enough so that somebody who's sitting can get their breasts on the mammography machine. And then making sure that people who use wheelchairs and other devices can get weighed. And so here's a wheelchair accessible scale. And then a requirement that for inpatient facilities, 10% be mobility accessible and that those be dispersed proportionally by medical specialty. So a little bit on terminology, tips, and resources. Before asking somebody, before helping somebody, you want to make sure to ask somebody, can I help you? Some people are going to take offense at being asked. Most people won't. Most people will appreciate it, but you definitely want to ask before acting. You want to speak and look at the person with a disability, not their companion. And don't make assumptions about what people can do and can't do, sex, employment, living alone. Be sure to tell person what you're going to do before doing it. And I've certainly noticed in the last 10 years that medical providers have gotten really good at doing this for everybody. Extremely helpful. And then using diagrams and pictures in addition to oral and print communication. And I think most medical providers have gotten really good at having those visuals in addition to just explaining. Terminology, which is always evolving. Disability is in, handicap is out. Some no-nos, handicap, crippled, wheelchair bound, confined to a wheelchair, mentally retarded. Those are terms that we do not use. And then there's different opinions about this subject. There's person first language. For instance, person with a disability rather than disabled person, or person with diabetes rather than diabetic. But some people actually take on what's called identity first language, and they want to be called autistic rather than person with autism. We recommend, and what we do, unless we're told otherwise by people, we use person first language. So Ms. G has epilepsy, not she's an epileptic. Mr. C has an addiction to alcohol, not he's an alcoholic. So all of this is part of the Department of Justice's barrier-free healthcare initiative. And the goals of the initiative are to ensure effective communication for people who are deaf or hard of hearing, access to medical care for people with mobility disabilities, and access for people who have HIV/AIDS. The enforcement is by the U.S. Attorney's offices and the Department of Justice's Civil Rights Division. And here's the website. We will be sending the slides out, so you'll have access to this website. Just a quick note about, this stuff costs money. Hiring sign language interpreters, assistive listening devices, exam tables. So there are tax credits and tax deductions. The credits are for any kind of improvement to accessibility. It could be you're putting in a ramp or providing braille or an audio recording or sign language interpreters or any kind of adaptive equipment. The deductions are just for alterations to improve accessibility to the building itself. So that's our presentation. We've got about 6 minutes for questions. And I see that there are a bunch from Sue Phillips and a few others. So I'm going to go down and use the Q&A feature for your questions. So Sue asked, with COVID around, there's a difficult time to educate hospitals and related medical sites to get clear masks. What is the best way to tell them? Been anxious in deaf community, including deaf blind, more frustrations. Yeah, I mean, obviously this is part of why we're holding this presentation. I think to the extent that you've got hospitals and medical care providers in your community, probably going to want to contact them, find out, maybe who the patient advocate is, or go right to the top and contact the head of it. But yeah, we need to make sure that people understand their obligation to use clear masks. Another question from Sue, with domestic violence victims who are deaf or hard of hearing or deaf blind, do they have the same ADA protections? Yes, they do. They are considered people with disabilities with rights under the ADA. And then another question, I assumed that applies to deaf certified interpreter too, to fit patients' communication needs with ASL interpreter. It could be any kind of interpreter that somebody needs. So it's not necessarily ASL. I don't mean any kind of interpreter. It's not, ADA doesn't require that you provide a Spanish interpreter, but if you need a Spanish sign language interpreter, then yes, that would be an ADA issue. From Holly, I work in healthcare settings that are not bound by EMTALA. We have had a few instances of patients who cannot wear masks, refusing the accommodations and modifications we have offered, such as virtual visits, if a physical exam is not required. They instead insist that they come in without wearing masks. Are we able to deny seeing them in these instances when our attempts to accommodate them have been refused by the patient? I don't know what EMTALA is, so I can just say that if you feel you can't figure out a method to get the direct threat level below direct threat, to get the safety issue below direct threat, that there's no means to do that. And certainly if somebody has access and is able to do, to do virtual visits, then yes, I would think that you could deny seeing this. I see Stacy would like to pop in and answer this question. So Stacy, you want to say something?
Sure. Well, yes, I mean, I would, if you feel like you can't reduce the level below direct threat, I would certainly document what you've provided and the decision that you made on top of that, so that when if someone comes back later and they file a grievance, you'll at least know why the decision was made the way it was.
Okay, good. Let's see, where can a person get trained as an ADA coordinator? It is a national certification program. So if you email Stacy or me, Mary, we'd be glad to get you more information. Laura says many states have agencies that specialize working with that population. I guess I'm not exactly sure. And then anonymous, are you allowed to ask someone if their animal is a service animal? I thought this was not allowed. Yes, you may ask somebody if their animal is a service animal. You may ask somebody if this is an animal that's needed because of a disability. You may ask somebody what work or task the animal has been trained to perform. And Stacy, do you want to speak up on somebody's question?
No, you've done fine. Are there any other questions that people might have before we wrap up?
Let's see, Laura still had a question about why don't more people who are blind or losing vision don't make the attempt to learn Braille, and I'm not exactly sure, but we did get a request, thank you very much, to read the screen, which we forgot to do. So the last screen is contact us with any questions, thank you. And then Stacy Hart, New England ADA Center, shart@newenglandada.org, Kathy Gibbs, Gibbs at newenglandada.org. Phone number is 1-800-949-4232, New England only. If you're in another part of the country and you dial that toll-free number, you will get the ADA Center that's in your part of the country. And then our general number is 617-695-0085. So everybody, we're at 11:30. Thank you so much for your participation. Please do get in touch with us if you have any questions or any comments, or if you would like I think we're going to be sending out the presentation. Isn't that right, Stace?
I can absolutely do that.
Yeah. Okay. All right, everybody. Bye-bye.